Now let's get started. The Champions for Care Committee of Missouri Baptist Healthcare Foundation is excited to present an overview of genetics and breast health. Champions for Care are donors who support special projects focused on improving care for our patients. So many times I have heard from my friends, oh, I don't need to get a mammogram. Breast cancer doesn't run in my family. We have a panel of experts tonight who will help us understand why we need to create a culture of annual screenings and promote genetic testing to reduce the risk of breast cancer for our friends and family. Now, I am so excited to announce our first speaker, Summer Chowdhury, Medical Director of the Breast Healthcare Center. She is well known as an expert in her field. Dr. Chowdhury is from St. Louis, but I'm not going to ask her where did she go to high school. In addition to her work at MOBAP, she has a huge reach collaborating with our other BJC facilities in Rock Hill, Sunset Hills, Ellisville, and Sullivan. Summer, I'm going to turn it over to you.
Okay, thank you. Can we go on, move to the next slide? Thank you for having me, Deborah. So I just want to give a very brief presentation about breast cancer, facts that I think Deborah touched on, but things that are relevant to mammography and women's health. And so I'll start out with some basic facts that you may or may not know, but 1 out of 8 women will get breast cancer in their lifetime. You probably know either a relative, a neighbor, another acquaintance or friend who may have breast cancer, and maybe they did really well with it and maybe they didn't. Next slide. It's 3 out of the 4 women who are diagnosed with breast cancer have actually no family history of disease and are not actually considered high risk. And I think this point needs to be driven home. Breast cancer does not have to run in your family for you to get breast cancer. It's oftentimes the result of random bad luck. And there's some other factors such as, a strong smoking history or drinking history, and some other hormonal therapies that can also increase your risk. But it does not necessarily have to run in your family for you to be susceptible to breast cancer. Next slide. 1 in 6 breast cancers occurs in women aged 40 to 49. So, someone tells you that breast cancer is a disease for older women. That's not always true. We're seeing more and more women, even in their 30s, be diagnosed with breast cancer. Women in their 30s to age 50 might have young children at home. That complicates the treatment and their follow-ups, but you have to realize that it's not just a disease of older women. It can be, diagnosed in younger women who are at the prime of their careers, have small children at home, who have a very busy life. So that's an important thing to remember. Next slide, please. Mammography has helped reduce breast cancer mortality in the U.S. by 1/3 since 1990. That's kind of around the time when widespread screening mammography programs were initiated in the United States. So it has clearly helped to decrease the breast cancer deaths that have occurred. And that's all due to the fact that mammography picks up cancers before they often metastasize or become, too difficult to control with your standard oncologic and surgical treatments. Next slide, please. So the American College of Radiology and the American College of Obstetricians and Gynecologists recommend that asymptomatic women get yearly mammography, that's the screening mammogram, beginning at age 40. There are different organizations in the United States that have different screening recommendations, but the American College of Radiology and ACOG are very strongly in favor of annual screening mammography beginning at age 40. For patients who have a strong family history, that screening mammography actually can begin earlier. That's often based on a risk score for patients who have a risk score that puts them at a higher risk, say 20% or greater. Screening mammography is actually recommended as young as age 30. But for the vast majority of women who have no family history, 40 is a good time to start mammography. Next slide, please. So what is a mammogram? This is a mammogram. This is one view of the right as well as the left breast. Can you go to the next slide? And this is another view. This is kind of a view from side to side. The first picture that I showed you was a view from top to bottom in the mammogram machine, which of course can be quite uncomfortable, but you know, it's only once a year and the pain is brief. So next slide. So if you Google breast cancer and mammogram, these are the kinds of pictures that pop up. You can probably see there's something abnormal in this breast, something irregular looking, something kind of bright in this top part of both breasts. That's a pretty big cancer. Anybody can see that. Now go on to the next slide, please. So our job in the world of mammography and at Missouri Baptist is to find cancers that are much smaller than that. We don't want to find cancers that the patient is feeling. We don't want to find cancers that can be seen across the room. We want to find the small, tiny cancers that, you know, patients can undergo a smaller controlled surgery and that the cancers have not metastasized to the lymph nodes in the axilla. That's the goal of screening mammography. And that's why the 1 year interval is important, because sometimes cancers can be quite aggressive. And if you wait 2 years or wait 3 years for your screening mammogram, you know, a small cancer will double in size or triple in size, depending on how invasive and aggressive it is. Next slide, please. So if you look at this mammogram now, you probably don't know exactly where the cancer is just looking at these images. And this is where your friendly radiologists come into play. We read these images and we look at them very carefully and we compare them with your last year's mammogram, and we go back a couple of years to see, hey, is there any difference in any one area of the breast that might, you know, bring kind of pique our curiosity. So this is a mammogram, and it looked like when we compared it to the old images that there was some sort of nodularity that was developing in the top part of the breast and the outer part of the breast. So we had this person come back and we did some additional imaging. So what is that additional imaging? Let's go to the next slide. So then we basically, you can think of it as magnifying or like kind of focusing and zeroing in on the particular area that catches our eye and that demonstrated a change. And in that upper outer part of the breast, we saw a little tiny nodular density, and it looked like it was irregular, it looked like it had changed, and it doesn't go away even though we're putting a lot of pressure in that area on the mammogram in hopes that there isn't anything and that it's just, you know, breast tissue kind of overlapping itself. But it didn't go away, it stayed. So then we recommended ultrasound. Next slide. And so here was the ultrasound. And on ultrasound, again, this is the same technology, you know, that is used to visualize little babies before they're born. We use this in mammography. And you see that this patient had this tiny little irregular area. You can see the nice and gray breast tissue, and then you see this darker area, kind of the shadowing area in the center of the image. And that's the cancer. And that's what was biopsied and diagnosed. And so you can see we're trying to catch these small cancers. This is not a problematic cancer. This is a cancer that can be treated with something called a lumpectomy, which is a localized excision. And hopefully, you know, this patient will go on to do very well. Next slide, please. Briefly, I just want to touch on one other issue that I think is very relevant to mammography. These are the different types of density someone's breast can have. And you've probably heard of this vaguely. You may or may not know what we mean when we say your breasts are dense. Each mammogram, when the radiologist reads your mammogram, they try to categorize your breast as either fatty, scattered fibroglandular, heterogeneously dense, or extremely dense. Now, why is this so important for us? Well, because you can see that it's probably a lot easier to spot an abnormality in that breast that's labeled fatty than it is in the breast that's labeled extremely dense. And so if you are in the dense category, well, it's harder for us to diagnose your cancer because there's so much other tissue there that we really have to, number one, take our time, which we do, but also it's often challenging to even see small or even large masses the more dense you get. This is kind of a hereditary thing. It is not, there's nothing you can do to control your breast density. So it's sometimes, people will ask, well, what can I do to become less dense? And there's not much you can do, but there are things that, you can do to help your chances of being diagnosed early if you have the more dense breasts. And I'll talk about that in a minute. Next slide, please. So again, Missouri has a law and multiple other states have a law that says that you need to be notified of your breast density because it kind of tells you and it tells your doctor that, hey, maybe mammography is not enough for me. Maybe I need some additional type of screening. Next slide. And so what can that entail? Well, one of the best things that's happened in the past couple of years is 3D screening mammography, which is a way to look at breasts, in smaller sections. Instead of having a 2D image, now we can go through the breast like in very thin sections. And insurance has actually begun to cover it over the past, several years. Lots of states have passed laws that require coverage for 3D screening mammography because it is that good and because it's much better at detecting small cancers in patients who have, especially in patients who have dense breasts, but across all densities. So that's the first thing. Always do a 3D screening mammogram, and that's pretty much the standard of care at most breast centers at this time. Very rarely will a patient say, I don't want 3D, then they will have a 2D mammogram. Also, some of our patients who have more dense breasts and say, maybe a strong family history will consider doing annual screening with ultrasound. Also, patients who have a very strong family history of breast cancer will do an MRI. And then clinical and self breast exams. Maybe your doctor feels a lump or you feel a lump. Don't ignore it. Come to us and we can always do an ultrasound and look at that area closely. Next slide, please. And what can you do to prevent breast cancer? Exercise, eat healthy, stop smoking, limit alcohol intake. Those are the things. So nothing, you can't do anything fun, basically. You just have to be very rigid and strict. And hopefully that will substantially decrease your chances of getting breast cancer. And of course, your annual screening mammogram is the number one thing that can help you in diagnosing the breast cancer early. So I'm happy to answer any questions or if we want to go on to the next speaker. Thank you.
Thank you, Summer. Our next speaker is also an expert in her field, Heidi Beaver. Heidi is a board-certified genetic counselor with over 40 years experience in reproductive and prenatal genetics. And in 2014, she added cancer genetics. Heidi, I find DNA sequencing to be fascinating. Can you share your findings on genetics, risk factors, and breast cancer for us? Is Heidi?
Yes,
okay,
I need
you are
here. Absolutely. First of all, I would like to address some myths that people hear about hereditary cancer, not only breast cancer, but other cancers. The first is that if you don't have a hereditary cancer gene mutation, you won't get cancer. As Dr. Chowdhury remarked, 3 out of 4 individuals with breast cancer have no family history. So family history is important. It can increase your risk dramatically, but not having a mutation does not protect you. Most breast cancers do occur sporadically. Secondly, if you have a hereditary cancer gene mutation, you will definitely get cancer. And that's not true. There are very few genes for cancer where the risk is 100%. Basically, having a breast cancer gene mutation increases your risk, so it's not a given. And we actually classify the mutations as being low risk, which means it increases the risk up to twofold, so maybe up to 26%. A moderate risk gene increases our risk 2 to 4 times the average. So that might be from about 25% to 48%. And then the high risk genes increase our risk by more than 4-fold. So 50% or greater risk for breast cancer. There is a strong misconception in the community that if you do have a hereditary cancer gene mutation, like one of the BRCA genes, that you will be forced to have risk-reducing mastectomy. Our screening has gotten to the level where that's not, it's a very personal decision. It's not pushed. Screening is good if you have a high risk, as Dr. Chowdhury said. We recommend starting screening at a much earlier age, sometime as young as 20 to 25, depending on the gene. Using MRI technology, which is more sensitive in addition to mammograms. And we have the option of what is called chemoprevention, which is using medications, oral medications, that can help reduce our risk, as well as lifestyle changes. The one exception is if you have a gene that increases the risk of ovarian cancer significantly, we do typically recommend removal of the ovaries and the fallopian tubes after childbearing is complete, and usually by 40 or 50. And that's simply because there is no good screening for ovarian cancer, and it tends to present very late in the disease process and does not have a great prognosis. However, women who have not had breast cancer can use hormone replacement therapy after that procedure for the menopausal symptoms that occur earlier than average. Another myth is that men cannot get breast cancer, so you don't have to worry if I only have sons in terms of being tested for my family history. Men can indeed get breast cancer. It's nowhere near as common as in women. But for instance, with the BRCA2 gene, they have up to a 10% risk. Also, most of these genes don't increase the risk just for breast cancer. Many of them increase the risk for prostate cancer, which is obviously male specific, as well as for cancers that occur in males and females, maybe pancreatic, colon cancer, malignant melanoma. So knowing that you have a gene mutation that increases the risk for breast cancer can be helpful for males as well as females. There's also a myth that is still perpetuated by a small number of doctors that if the history is on your dad's side of the family, you don't need to worry. Half of our genes come from our father, half from our mother. And so if your father has, for instance, a mother or a sister who has a hereditary cancer gene, he could have it because his risk of breast cancer is so low and he obviously can't get ovarian cancer. It might not show up in him, but it would still be important for him or you to be tested. So it matters what's on both sides of the family. And finally, your doctor might say that he can do genetic counseling in his office, so he doesn't need to see a genetic counselor like me. And we'll address this a little bit at the end of the presentation. So next slide, please. As Dr. Chowdhury pointed out, most cancers are sporadic. They occur due to an accumulation of harmful changes in genes in random cells, and it tends to take many years to get enough changes in any one random cell for cancer to develop. That's why most breast cancers and other cancers occur after the age of 60 or 65. About 5 to 10% of breast cancers, maybe up to 20% of ovarian and pancreatic cancers, are hereditary, meaning there's a single altered gene that increases our risk, and that can be passed from parent to child. So it was in the egg or the sperm responsible for our conception, and it's in every cell in our body. So why don't we see increased risk for every kind of cancer with these genes? It's because every gene doesn't need to work in every cell. So you will see cancers associated with organs where that gene has a job to do. For instance, my eye color gene probably doesn't need to work in my ureter. So a change in that gene in the ureter wouldn't cause any problems. Then we have this middling group where we see more cancer of a certain type than we should by chance, but we can't find a specific gene in the family that explains that. So those families might have low-risk genes, maybe several low-risk genes that we're not able to identify. They might have a change in a gene we have not discovered yet, or they might have a change in a gene that our current technology is not able to detect. Genetics is still a very young field compared to many other areas of medicine. And we only know what about 60% of our genes look like and can determine what their job is. So familial cancer might be due to a combination of several inherited genes acting together, plus some triggers in the environment. So there are issues in our environment that can cause genes to mutate in individual cells, radiation, viruses, chemicals. For instance, if you watch TV, you might see ads for the papillomavirus or HPV vaccine for young children. And that's because that's a virus that increases the risk, can cause mutations in cervical cancer cells and increase the risk for that. So we have things in our environment as well as lifestyle factors that probably contribute to those familial cancers. Next slide. So yeah, I'm genes on the brain. If we look at hereditary cancer genes, and this is kind of an old slide, but if you look at a panel of, say, 25 genes associated with hereditary cancer, in the individuals with breast and ovarian cancer, nearly half will be accounted for by the two that get all of the publicity, BRCA1 and BRCA2. Often they're mispronounced as BRCA1 and BRCA2. But the founder of those genes named them BRCA1 and BRCA2. So that's the correct presentation or reference for them. Now, those genes, like I said, get all of the publicity. Angelina Jolie has one of these. There are multiple individuals in the Hollywood community, such as Christina Applegate, some men even with these. Beyonce's father has one of these, and that caused him to develop breast cancer. So these are the most common, but certainly not the only ones. We have about 3% that are high-risk genes, and as I said, they increase our risk fourfold or more. We have about 10% that we'll see that come back positive, and they're not in genes that are typically associated with breast cancer, so maybe there's an association there that we have missed in the past in studies, or maybe it's just by chance that we have an alteration in those genes. And then about 38% of the detected mutations are in those moderate risk genes, ones that increase our risk 2 to 4-fold. Next slide. So moving on to talking about genetic testing. Genetic testing is a very challenging area, and there are many issues that need to be presented. Testing for hereditary cancer is very complex in terms of understanding the genetic basis of cancer, basic genetics, changes in the field, new technologies coming up. And most of the time, the doctor in your office only has 2 to 3 minutes to explain all this to you. So it's not uncommon when a doctor gets a positive result and they refer to me, I have to start from scratch. Whereas the patients I've seen have heard all that background information and an explanation of the types of results they might get and what those might mean. Many organizations recommend counseling by a geneticist or a genetic counselor before and after testing, and some insurances require this. They might have an exception if you have a new diagnosis of breast cancer and a surgeon wants that information to determine if maybe you should have a bilateral mastectomy due to the high chances of getting a cancer in the opposite breast. Cigna requires genetic counseling beforehand, Blue Cross Blue Shield. So this is something that's fairly common. And if you don't get it done, then you'll be stuck with the bill. Also, research has shown that genetic testing ordered by people who are not certified in genetics can actually result in harm. Well, how can that be? Number one, they ordered the wrong test, which didn't really address the family history. If you don't know what to look for, you're not going to order the correct panel of tests. So we rarely, if ever, order only BRCA testing, because that only accounts for half of the hereditary genes that can be involved in cancer and involving the breast and the ovaries. And as a result, if they order the wrong test and it comes back negative, they're going to give that individual false assurance that they don't have an increased risk, when in fact they might. Also, if they get a negative result, they might not realize that you still have to take the family history into account and use risk models to determine the chances of a cancer in their patient. So if I have a family history of breast cancer and I get a negative genetic test back because none of my relatives with cancer were able to be tested, number one, I don't know if that test was appropriate or if there even was a hereditary cancer gene in my family. So we have to take in the possibility that there was, and that's what risk models do. They take into account lifestyle factors, age, body mass index, genetic testing results, and the family pedigree, and give us a risk. And as Dr. Chowdhury mentioned, if that risk is 20% or greater lifetime, then you're eligible for screening at a younger age and with better modalities such as MRI. The other issue we have is there are multiple reports of results being misinterpreted because these lab tests don't just come out positive and negative, and often looking at the results, it's hard to determine what might be abnormal and what not. And so there have been women, and I have unfortunately seen some of these, whose doctors misread the report and they had risk-reducing surgeries that caused a lot of time away from normal life, a lot of adjustment, and it wasn't necessary. So interpreting the testing, it's very important that that be done by somebody experienced in genetics. There is a class of results called variants of uncertain significance, where we don't have enough data to know if that's harmful or not. And that's where a lot of the misinterpretation comes in. Many physicians assume that that's bad. But historically, as we have gained more data on those uncertain variants, the ones that get reclassified end up being harmless in 90% of the cases. So we want to first do no harm and not act on those variants until they're reclassified as harmful, if that is the case. The other issue that I find is with people who had not had cancer, their doctors aren't aware or don't take the time to talk about possible genetic discrimination. So we don't have issues with that when it comes to health insurance. And if we work for or look for work with a group that has more than 15 employees, we don't need to worry. However, there are only a few states that provide protection against genetic discrimination when it comes to obtaining life insurance, long-term care insurance, and disability insurance. And this particularly worries me with young people. Many of them say, well, I already have life insurance through my employer. But we know that most people change jobs every 4 to 7 years. And what might happen is that you have a positive result. If the insurer asks about that, a life insurance questionnaire, you have to answer honestly. Otherwise, you could be sued for insurance fraud, which happened with a lot of smokers in the past, where they were able to prove that they were smokers and they did not pay claims for lung cancer deaths. So It's important to get this all in line before any testing is ordered or any results come back. And I say ordered because they consider an order or a pending test to be having had testing, even if it comes back negative. So they could decline to cover you based on that. So those are some of the areas that a genetic counselor will spend time reviewing and assessing that your private physician might not be able to handle in his daily practice of seeing patients for 5 to 15 minutes. So that's just some information about cancer genetics. There is much, much more. Usually I spend 45 minutes to an hour assessing an individual and explaining all this information, what kind of testing is available, how it may or may not be helpful to them, what kind of results they might receive, and so forth. But I'm very happy to answer questions at the end of the presentation. Thank you.
Thanks, Heidi. So also with us tonight, we have, and many of you probably have seen her over at MOBAP's Breast Healthcare Center. It's Tanya English. She's the manager of breast healthcare and lung screening programs, and she oversees breast health programs at MOBAP, Rock Hill, Sunset Hills, Ellisville, Sullivan, and MOBAP's Mammography van. And her compassion for her patients seems to be in the heart of all of her programs. So I'm going to turn it over to you, Tanya.
Great. Thank you so much, everyone. Happy to be here. And so tonight I'll just be giving you just a brief overview of the Breast Healthcare Center. So pictured there is our beautiful Breast Healthcare Center that was reimagined about 6 years ago. We really wanted it to look spa-like. So someone mentioned earlier that no one really wants to come in for their mammogram once a year. So if they're going to come in, we want them to feel as comfortable as possible. So our vision and our mission just internally in the breast center is that we will provide consistent quality breast health services in a comfortable and caring environment, keeping the patient at the center of our focus. So that's really what we do every day. And we want patients to feel that the moment they walk into the waiting room and are welcomed by those beautiful hydrangeas. So some of the offerings that we do at the breast center are screening mammograms. That's just annual mammography. We also perform diagnostic mammography. So that's performed, as Dr. Chowdhury mentioned earlier, if a patient has already had a diagnosis of cancer, or if they have had an abnormal screening mammogram, they will come back for a diagnostic. We also perform DEXA scans, better known as bone density studies. Breast biopsy, we can do that in several different projections. We can do it upright, sitting upright, which many patients find a lot more comfortable than the traditional stereotactic, which is prone. You're lying on your stomach, which is really not comfortable for many women. And then lastly, we can do an ultrasound guided biopsy. We do surgery localizations, MAG seeds. We can do them up to a couple weeks before surgery is performed. Breast ultrasound, high risk program, we offer that free of charge. Heidi mentioned that earlier. Patients come in, they fill out a history form, and we talk to them about their potential risk for breast cancer, and then we can follow them through the journey, and then we can potentially order some additional imaging for surveillance like MRI and also ultrasound. And then also we offer genetics, again, free of charge for several different tumor sites, as Heidi mentioned. Next slide, please. These are just a few of our current stats, just so that you kind of get a feel for who we are and what we're doing. We see about 120 patients a day in the breast center, consisting of lots of different types of patients, screenings, biopsies, DEXA scans. And, so that's pretty busy. That really equates to over 30,000 patients a year. And we're open Monday through Friday, and usually open 1 to 2 Saturdays a month. And these days, in order to accommodate all of our patients and particularly working women, we even have extended hours where we're open until 5:45 in the evening. And then, of course, we are rebounding from COVID. Last year, we did not do screenings from March until the end of May. But now we're getting our patients back. But something else that came out right after COVID, when people started getting their COVID vaccines, from the Society of Breast Imaging, they made a recommendation that women should not have mammography for 4 to 6 weeks after their COVID vaccine. So we started to see a lag, but now we're starting to see more volume. So we're really expecting June through January to be very busy. Traditionally, as everyone knows, the fall is busier for mammography, with October being Breast Health Month. We are predicting June through January will be our busy season this year due to COVID. Our patient satisfaction scores are great. We have a 3-month average of 90, and yesterday I heard that we were actually rolling at more like 95%. So we have a constant rigor around patient satisfaction, and we're always tweaking things to make sure that patients are very satisfied with our services. Next available diagnostic is something that we talk about every day. Patients want to get in. If they know that they've had an abnormal mammogram, they don't want to wait 2 weeks or 3 weeks. They want to get in as soon as possible. So we really try to get them in within a week, and we're exceeding our goal right now. There's new branding and marketing coming around the corner. Instead of doing everything that we've been doing and having everything pink, we're looking forward to launching some different colors and really just having new branding coming very soon. In quicker online scheduling is something that we started a few years ago, and it's been very successful. We're one of only a few hospitals in the St. Louis area that offers this. We all make our airline reservations, our hotel reservations online. So why not schedule your mammogram when you're sitting on the couch at 8 o'clock at night? So our patients are able to do that, and they love it. Next slide, please. And then this really just tells a little bit about our multiple accreditations, where some of them are voluntary, but a few of them we just decided to do because we've got such a high quality program, and we have a data analyst who does all of our accreditations, and we're really happy and proud to have her part of our team. And one of our accreditations I want to talk about, NQMBC. We are the only facility in the whole state of Missouri to have a comprehensive breast center of excellence as awarded by NQMBC, which stands for National Quality Measures for Breast Centers. So that's a huge feather in our cap, and we're very proud of it. Next slide, please. And this is just a visual just to show really our structure. So the Breast Healthcare Center is the umbrella, and then underneath that we have several screening centers. We've got locations at Rock Hill. They do about 3,000 patients a year there. We have our mobile mammography van. Again, not thinking about COVID. Previous years, we've done about 3,200 patients a year. We go out almost every day and also some weekends. Sunset Hills, we do about 3,500 patients there annually. And then Ellisville is a brand new location that opened in February, March, and they're off to a really great start as well. And then this is a visual of our van, which is about 3 years old now. And then it just goes to show how many counties we serve. We go to 31 counties throughout the state of Missouri. So sometimes we're traveling up to 2 hours away, but we really want to be able to serve the rural population of patients who really otherwise would not be able to have mammography. And it really helps us with our Missouri Baptist mission, which is to improve the health of the people and the communities we serve. And then this is just to show what we're doing in terms of community and population health. You don't have to look at all the numbers or the graphs to really understand the slide. What we're doing, we want to increase recognition of screening African American women to reduce healthcare disparities in that population. So we have a goal of screening about 20% more African American women in the breast healthcare center and on the van. And then further, we also have a goal for any abnormal patients to come back to Missouri Baptist for their diagnostic follow-up. And then further, any of those patients, if they need follow-up from their diagnostic to get a biopsy, we would like 75% of them to come back to Missouri Baptist. So we're tracking all of those, and we talk about that monthly. And that's also a BJC initiative and goal, not just Missouri Baptist. Next slide, please. And then this slide really just shows the Champions for Care program. So just to give you some statistics around that, of course, with our beautiful van that's only 3 years old, 5,350 women were diagnosed with breast or are diagnosed with breast cancer each year in the state of Missouri. And the need to find cancers early is huge. We find cancers early, we can treat cancers better. Again, the van travels to 30 counties in Missouri plus St. Louis area, so that's 31 total. Our catchment area really extends to about 2 hours away, and 1/3 of our patients are under or uninsured. Thank you.
Okay. Our last speaker tonight is Lynn Hayward, Certified Oncology Nurse Navigator. She has nearly 40 years experience in oncology. She has perfected the role as a nurse navigator. Her kindness, respect, and follow-up with patients is seen daily. Lynn, tell us about your role as our nurse navigator and the impact you have on our patients and the communities that we're serving.
Okay, thanks. Can you hear me?
Yeah.
Okay, great. So welcome to my office. Missouri Baptist, about 10, 12 years ago, initiated a very unique role in that they realized that women who had been diagnosed with breast cancer needed more upfront support and guidance, and not really knowing where to turn. They were lost, they didn't really know who to call, and so the navigator position was started. And for me, having 40 years of experience, I am very qualified for the role. My job is to help women, but my desire in my heart is to help them to be better prepared, less afraid, and more informed for their journey. This is not a journey that they asked for. This is something that we've told them, threw them on the bus, and now they're headed down the road, and they need some help. So I primarily get my referrals from the Breast Healthcare Center and from our surgeon, Dr. Paul Yazdi's office. Occasionally I get a referral from an outside source. When a woman comes in to have a mammogram and it's suspicious, she needs a biopsy, and that biopsy is reported as cancer, that pathology comes to me. And once I get that pathology, I call the referring physician and I let them know that their patient has a new breast cancer. And with their permission, I will call the patient and contact them and get them set up for next steps. That would include seeing our team of surgery, medical oncology, and radiation oncology. After that's done, I call the patient. And I think that's where my skill set probably comes in the most. It's usually a phone call. Today I had somebody in my office explaining their diagnosis, but that's not typical. Usually it's a phone call. And I am the voice that they hear to tell them that I'm sorry, to let them know, but they do have a new breast cancer. I tell them what's the cancer diagnosis. I tell them the plan of care. We talk about their concerns and their questions, and I have a lot more time than the physician does to go through and explain those details. So for me to spend time with them, it can range from 20 minutes to 30, 40, even an hour, depending on what kind of questions they have. Any new breast cancer patient that I speak to gets all of my contact information. So they get my email, they get my office number, and they get my personal cell phone. So I'm available to them 24/7. They're very afraid initially, and sometimes they just need somebody to call. They need somebody to bounce a question off of. They've gone home, talked to their family, and now their family's asking them questions, and it's 7 o'clock at night, and they don't know what to do. So I don't get a lot of calls, but I do speak to patients over the weekends and sometimes in the evenings. As I said, I do coordinate all of their appointments with our team, and so all these ladies have to do is just answer their phone. They don't have to make a phone call, explain their cancer, what the nurse told them over the phone. They will just get phone calls. So we make it really easy for them as they're starting in their journey. People ask me, how do you do what you do? You've been an oncology nurse for 40 plus years. I mean, don't you feel sad making these calls? And the truth is, yeah, it is sad. I don't like to tell women they have breast cancer, but I do know that the information I have for them, they need to hear so they can be empowered for their journey. And so for that reason, I know I'm helpful to them, and that is a really esteeming part of my job because I know I am helpful. I will meet all of the new patients that I have talked to in the surgeon's office on the day of their consultation. I review their pathology and any updates that might have come through, additions to their pathology that wasn't available when I first talked to them. I tell them what they can expect for the day, and they get a journal from me that has all of my contact information, their appointments, a picture of me without a mask, and it's a great tool. I think patients really like having a one-stop shop for all of their information and appointments. My job as the navigator is primarily on the front end. I do talk to patients throughout their journey, but I am the one that's helping them after they hear the information that they have cancer to helping them be at a place where they can hear what they need to hear to move on to the team and to get cured. Once our patients see the medical and radiation oncologist, they have a really great group of nurses in their department that can help them with chemotherapy kinds of questions and radiation questions. But my job on the front end is really helping them get from, I cannot believe you've called me and told me I have cancer. This is the worst thing, to getting them to where they need to be. One final thing that I do as the navigator, which is a really important part of my job, but I coordinate weekly breast conference, and that is a weekly meeting at 7 o'clock on Wednesday mornings that I co-facilitate with typically Dr. Chowdhury, sometimes Dr. Morrison, and we review every patient that we have contacted that week who has a new diagnosis of breast cancer. And this virtual platform engages our entire team. So our surgeon, medical radiation oncologist, pathology, radiology, social workers, our occupational therapist, and our research department all join in on this meeting to discuss and collaborate every single patient's care. And once the conference is complete, all that information is disseminated to the team and then back to the referring physician so that they know what's happening with their patient. And I think it's a way that we can provide excellent care to our patients throughout their entire journey. It just kind of puts a nice little bow on it. That's really all I wanted to tell you. I know we're running short on time. Thank you for joining. And if you have any questions, I'd be happy to answer too. But Debbie, I'll turn it back over to you.
Thank you, Lynn.